Our next speaker is Dr. Greg Vanichkachorn, or is widely known as Dr. Van. Dr. Van is an occupational medicine physician and the medical director of the Mayo Clinic COVID-19 Activity Rehabilitation Program. He has over 20 years of experience in treating patients with work-related injuries and illnesses and is an associate professor of medicine at the Mayo Clinic College of Medicine. He is passionate about improving the quality of life and well-being of his patients, especially those who have been affected by the COVID-19 pandemic. Dr. Van will present on symptoms, treatment, and rehabilitation of patients with long COVID. The floor is yours.
Excellent. Well, thank you for that wonderful introduction. Again, my name is Dr. Van. The full thing is actually Vanichkachorn, but in the spirit of safety, everyone always shortens it down to Van. It's good to be here. Today, we've heard a lot about the overall impact and state of long COVID. But for my presentation, I actually would like to take you from the macrocosm level to the microcosm and discuss long COVID at the clinical level and really share with you what we deal with on a day-to-day basis when it comes to treating patients with long COVID and helping them regain their function. Specifically, here's the plan for my presentation. I'm going to talk a little bit about what we truly see on a day-to-day basis, go over some numbers about risk and prevalence, talk about biological plausibility, and then we'll go over the treatment. And the information from this slide, as Dr. Kavanaugh mentioned, comes from my experience working as the medical director for Mayo Clinic's first program for long-haul COVID, the COVID Activity Rehabilitation Program, which is affectionately known as CARP. We started seeing patients coming out of the ICU at Mayo Clinic with COVID all the way back in January, February of 2020-ish or so. And it was pretty apparent early on that some individuals were having difficulties getting back on their feet. We reached out to several of our colleagues to put together a treatment paradigm for these individuals. And as more and more patients presented needing care, the program became formalized in June of 2020. And since that time, we've had the opportunity to visit with hundreds of patients from across the world with long-haul COVID. So let's just start with some basics. What is long-haul COVID, or what we call post-COVID condition now? Well, it really depends on who you ask. Remember, this is such a new condition still that we don't have everyone using the same name for it. Just 6 months ago, I was using post-COVID syndrome. Now I use post-COVID condition. The media says long-haul COVID. The NIH says post-acute sequelae of SARS-CoV-2. Likewise, we also don't have a universal definition for this condition. The World Health Organization came up with their definition back in October of 2021, and you can see the elements here on the slide. The most important being that they apply this term for anyone who is having symptoms more than 3 months out after their infection. In contrast, the CDC, well, first of all, they call it post-COVID conditions like I do. And they apply this to anyone who's having symptoms more than 4 weeks out after their infection. So we have definitions, but unfortunately, they're not defining. Now, while this still remains nebulous, what we do have a better understanding, though, of are the kinds of symptoms that we see with long-haul COVID. In this slide, you can see the most common symptoms amongst patients that we have seen at Mayo Clinic for long-haul COVID. Now, at the very top are fatigue and respiratory complaints. Now, the fatigue that we see in this condition, it's quite something. It's not the fatigue that we see of having the flu or having a bad night of sleep for a few nights in a row. For example, patients will say something like they took their dog out for a walk around 2 blocks and they had fatigue and flu-like symptoms that lasted for 3 days. The fatigue is quite profound and, in my opinion, the hallmark feature of long-haul COVID. We also hear a lot about respiratory complaints like cough and shortness of breath, both with activity and at rest. Now, most people, they think about fatigue and respiratory complaints as long-haul COVID, but as you can see on this slide, we also see quite a few other things frequently. So neurological symptoms are equal in prevalence in our patient population as respiratory symptoms, things like headaches or tremor or tingling and numbness in the extremities. We also hear a lot about cognitive impairment, troubles with thinking. Almost 50% of our patients report this, and it's commonly known as brain fog. We also see a lot of sleep issues and mental health symptoms, even in individuals who have not had any previous history of a mental health condition. Now, while these are the most common things that we see, we also see some more unique, but certainly not rare symptoms associated with the condition. Things like new onset tinnitus, prolonged loss of taste and smell, hair shedding, syncope events, sinus problems, and most recently, a lot of GI symptoms. The takeaway point for these two slides is that long haul COVID is more than just fatigue and shortness of breath. It seems like every day we're still learning more about the types of symptoms that can be associated with this condition. All right, let's talk a little bit about risk factors. I know my colleagues have reviewed some of this information here, so just going to hammer a few pearls home here. The most recent information about risk factors actually comes from my colleagues in Mayo Clinic, Florida. In this past August, they published a paper where they went back and looked at about 3,000 patients they saw in their long-haul COVID clinic to find risk factors. And you can see their findings here at the bottom part of the slide. Things like psychological stress, female gender, and also having a very severe acute COVID infection. And this fits very nicely with what we have seen in our clinic and also previous research. So for example, all the way back in August of 2022, researchers, they looked at 730 patients to see if there was any relationship between the severity of the acute infection and the odds of getting long COVID. And what they found was, yes, having a severe infection made you at higher odds of getting long COVID. 3.62 for those who have a severe infection versus 3.01 for those with a moderate infection. But what's really important to realize as part of this study is that 56% of the patients reported having a very mild or asymptomatic acute infection. And this fits with what we have seen at Mayo. 75% of our patients actually had a very mild infection. So the important thing to know is that while having a severe infection can make you more likely to have long COVID, having a severe infection is not a requirement for long COVID. Now, what about vaccination? Does this make a difference when it comes to long COVID? Well, of course, I always remind folks that the best way not to get long COVID is to not get COVID in the first place. So yes, there is an effect there. But is there more of an impact? Well, the answer seems to be yes. My colleagues and I just published our findings after we looked to see if symptoms of long COVID differed between vaccinated and unvaccinated patients. And you can see in the slide what we found. Vaccinated individuals seem to have less symptoms if they experience long COVID, less abdominal pain, troubles with smell, or chest pain, or weakness. Now, the astute statisticians in the group will know that these are the kinds of symptoms that can interact with each other. And so we went back and did a deeper dive with the stats. And after we did that, the only thing that we found that remained statistically significant between the two groups was abdominal pain. Now, this may seem trivial, but GI symptoms, as I mentioned earlier, are becoming an increasingly recognized sequelae of long COVID, with some studies showing that 16% of individuals can experience symptoms like abdominal discomfort, food allergies, diarrhea, constipation, and so forth as part of their long COVID experience. And this can significantly affect the quality of life. The takeaway point here is that vaccination can help reduce the morbidity of long COVID, not only by reducing acute infections, but also reducing the symptoms that are experienced if someone develops long COVID. Well, how about prevalence? We've already reviewed this here, but just to hammer home, we expect that roughly 1 in 5 adults, or 20% under the age of 65, will come down with long COVID after an acute infection. If you are older, over the age of 65, unfortunately, your ratio gets worse. We expect about 1 in 4, or 25%. Now, there is some good news, though, in this area. It does seem that the prevalence of long COVID actually seems to be decreasing. You can see here in this slide, back in June of 2022, we saw about 19%. And as of January 2023, we are at 11%. And this fits with what we have seen anecdotally. Frankly, we're just not as busy as we were earlier in the pandemic. And it's often been said that the Omicron variant has been associated with less long COVID. I'm a little bit skeptical. I'm not sure if it's that or vaccination or the fact that there's more access to care and more recognition of long COVID that's resulting in this trend. But whatever is happening, I hope this trend continues as we go through the next variants. All right. So we very briefly gone over the symptoms that we see at Mayo for long COVID, some of the risk and prevalence and so forth. And that's what most people talk about when they talk about long COVID. But the often overlooked aspect about this condition is how it affects a person's ability to actually live their lives, both at home and at work. So let's take a closer look at some of the information. At the time of presentation to our clinic, 34% of our patients report having difficulties with some of the most basic activities of daily living, things like putting on their clothes, taking a shower, or using the bathroom. 82% reported difficulties with some of the more routine things like grocery shopping, household chores, cooking, and driving, and of course, work. Now, 63% of our patients reported being back at work by the time they presented for care at Mayo. Now, this sounds like a very rosy stat on the surface, but it's important to realize that the average time between infection and presentation at Mayo was 3 months. So, another way to look at this information is that 3 months out after the start of a COVID infection, only a little bit more than half of our patients were back at work. And of those patients that were back at work, about 50% of those folks required some form of work accommodation, like reduced work hours. And unfortunately, these functional deficits, they don't improve over time automatically. In a follow-up study at Cornell, 12 months out after an infection was found that more than a third of patients were still experiencing functional deficits like carrying groceries or climbing a single flight of stairs. Likewise, as mentioned by my colleagues earlier, the impact at work has been severe and doesn't go away. In a study to see how patients were doing 7 months out after their infection, the percentage of individuals who were fully employed went down from 72% to 44%, as well as the number of individuals who were working reduced hours or out of work went upward. So again, the takeaway point here is that yes, long COVID does cause some significant suffering amongst patients, but it also impacts their ability to function, to work, and also impacts our society because of this. All right, so now I want to address the elephant in the room. We've gone over the symptoms and the functional deficits that we see in long COVID. And the gut reaction that most people have when they hear this information is that this is just simply not possible. How can a virus cause so many different problems across so many different systems in the body for so long? Well, as remarkable as long COVID seems, what we are actually seeing with the coronavirus and long COVID is not novel, but actually a sequel. If we go all the way back to the 1918 Spanish flu, we have studies at that time that show that many patients were experiencing ongoing symptoms after the infection. We've seen similar things with the 2016 Ebola virus. We've seen similar things with the Epstein-Barr virus, which of course causes mononucleosis, which is associated with fatigue. We've even seen this in the previous coronavirus outbreak back in 2003, with some studies showing that 60% of patients were experiencing ongoing fatigue 12 months out after their infection. Why didn't we hear about it at that time? Well, that was a much smaller scale. So in addition to this historical precedence, there's also growing research evidence of an underlying biochemical process that can account for long COVID. Now, I don't want to lobotomize the audience here with the biochemical stuff here, but I'm just going to give a couple of examples. So for example, in February 2023, researchers looked at the serum of individuals who were experiencing long haul COVID, and they compared them to a bunch of other cohorts, like folks who were fully recovered after COVID, those who were in the hospital and recovered, and those who were never infected. And what they found was that in individuals with long haul COVID, they had greater amounts of still circulating viral RNA and spike protein, similar to the levels seen with an acute infection. In addition, both viral RNA and spike protein was found in 33% of the patients with long COVID, whereas that combination was not found in any of the other patient groups. Another example of an underlying immune process comes from studies looking at lactate dehydrogenase. A meta-analysis that was published in September 2023 found that individuals with respiratory and cardiac symptoms as part of long COVID had higher levels of lactate dehydrogenase. And this is a blood value that we see associated with things like pulmonary fibrosis. And one more, this is fresh off the press, just published this past month. Recently, researchers looked at 1,642 patients to see if there was a difference in inflammatory and immune system markers between individuals who had brain fog as part of long COVID and those that did not. And what they found was that those individuals who experienced brain fog had lower levels of immunoglobulin G, specifically IgG1 and IgG3. Interestingly, CRP, a test that's typically done to test for inflammation, was normal between those two groups. Now, I wouldn't be doing my job as a presenter and educator if I didn't mention some of the counter evidence out there as well. So, for example, back in August of 2022, researchers looked at 171 patients and put them through a neurological battery. And what they found was that there was rare objective evidence for any kind of neurological pathology. There was also high levels of somatization, and there was an association with pre-existing psychiatric conditions. So maybe long COVID is all due to a mental health condition. Personally, medically, I don't think so, but time will tell. But in any case, though, the primary takeaway here is that despite how impossible long COVID seems, there can be a possible biological explanation for what patients are suffering. And we should not just assume that this is all due to an underlying mental health condition or even something more subtle like a personality trait. All right, so let's get to the meat of the matter here, treatment. And before I go into this section, I have to say that there is currently no gold standard for treatment. And what we do at Mayo Clinic is piece together from the expertise of multiple medical experts, as well as drawing on our experience in rehabilitation. But again, somewhere else may do it differently. And with that disclaimer, let's just kind of dive in and first look at how we consider the overall evolution of the long COVID process. We look at the post-acute infection periods as basically three distinct stages. First is the post-acute phase between 0 to 4 weeks. And yes, this is an important phase. Remember, not everyone that has COVID gets better after 5 days, but not everyone who doesn't get better after 5 days goes on to have long haul COVID. Then there's the early long COVID phase between 5 and 12 weeks out after infection, and then the true phase, 12 weeks or 3 months more out after the start of an infection. Now, my work in the CARP program focuses primarily in the 5 to 12 week window. We have seen that if we can intervene earlier with these patients, get them on the right trajectory, they could have a more complete and faster recovery. If we zoom into that 5 to 12 week period, our treatment paradigm can basically be divided into 4 distinct steps. Step 1 is an in-depth interview with psychosocial support. Step number 2 is to evaluate for serious and/or common conditions that can occur after a COVID infection. Then we do our targeted evaluation in step 3, followed by rehabilitation. So let's dive into these in a little bit more detail. So step 1, psychosocial support. Now, I've had this slide in my slide deck since 2020, and every time I had to give a presentation, I hope that I can take it out. But as time goes on, this still remains germane to the discussion about long COVID, unfortunately. If there's one universal thing that I've seen amongst all patients with long COVID, it's that they feel abandoned. And it's unfortunately very easy to see how this may have happened. Long COVID is still a condition that is not well understood or well accepted. Providers don't know much about it. Remember, there are individuals out there who don't even think COVID was real, and convincing them that long COVID is real is impossible. So because of this milieu, patients who experience long COVID often get told some very unhelpful things, like this is all in your head, what you're going through is not possible, you're just faking it to get gains, and perhaps the most hurtful, you just need to toughen up and get with the program like the rest of us. Because of this, patients with long COVID, they often turn in on themselves. They start to ask questions like, what is wrong with me to have this kind of recovery compared to my spouse, to my coworkers, and so forth? This leads to guilt, self-doubt, fear, sometimes clinical depression, anxiety, even PTSD. So the most important thing and first step we do for patients when they come for treatment is we listen to them. We let them tell their story without bias and with lots of empathy. And when they are done sharing their experience, we let them know that their symptoms are consistent with hundreds of other patients that we have seen with this new nebulous condition, and that we are going to help them get better as best as we can. This initial empathy and validation is the most important first step when it comes to treating patients with long COVID. All right, so after we establish this, again, we move on to making sure that nothing else is going on. Remember, individuals who have an acute COVID infection, they are more prone to getting other conditions in the acute recovery period, things like a pulmonary embolism, or a secondary infection. So we always do a very in-depth evaluation, including a full history, a physical, and some diagnostics that you can see here. And you can tell by looking at this list the kind of things that we're looking for. So electrolyte abnormalities, ongoing infections like secondary pneumonia, a potassium problem, or underlying diabetes or thyroid issues. Now, if this seems like a very small list, please know that that is by design. When we first started working with patients with this condition, we pretty much did everything under the sun that we thought could be remotely helpful. So echocardiograms, chest x-rays, and such. And when we went back to look to see how helpful these tests were, what we found is that they weren't very helpful at all. So for example, of the 35 chest x-rays that we did, only one was abnormal, and it was like minimally abnormal, just showing some resolving infection. Similar results found with the pulmonary function test and echocardiograms. So the takeaway point here is that less is more when it comes to initial diagnostics, when it comes to long haul COVID. This is especially true for this condition because many patients with long haul COVID have very nebulous insurance coverage of this condition. So the last thing that we want to do for someone who's been out of work for 3 months is to give them a multi-$1,000 medical bill that is unnecessary. All right, step number 3, targeted evaluations. Well, what do I mean by this? It kind of draws on my previous point here. So we see some conditions that are frequently associated with the long COVID phenomenon, like pericarditis, pulmonary fibrosis, and headaches. But with that being said, we don't go chasing these kinds of conditions unless there is some sort of clinical indication. So for example, yes, we see a lot of patients who have shortness of breath as part of long COVID, but not everybody has that. And so we won't go chasing a pulmonary condition and doing all of these diagnostic tests of the pulmonary system if someone is not experiencing shortness of breath. But in any case, with the frequency we see these associated conditions, we're always keeping an eye out for these kinds of things and we'll order testing if necessary. Now, I don't have time today to go into the details of all of these boxes here, but I just want to share some treatment pearls and then you'll have my slides for reference. So first up, just going through the cardiac side of things. If we're going to do an evaluation for our cardiac problem as part of long COVID, we'll typically start with the ECG and the echocardiogram. And if we need to assess more so for things like inflammation, we'll do a cardiac MRI. If we need to assess for exercise capacity, we'll also do a cardiopulmonary exercise test. The most common symptoms that we see are myocarditis, new onset hypertension, and pericarditis. I'm happy to report that we have not seen some more of the serious cardiac outcomes that have been mentioned in earlier research, like a pulmonary embolism or myocardial infarction. I've had one case of each of those conditions, and they're probably more so related to the underlying pre-existing conditions rather than the long COVID phenomenon itself. Pulmonary system. We hear a lot about shortness of breath, as I mentioned. It's important to remember that shortness of breath can last for several months after a COVID infection and still not be associated with long-haul COVID. In fact, this is so common that it's currently recommended that we don't do any kind of pulmonary evaluation until 3 months have passed after an acute infection. So if someone is still suffering 3 months more out after an infection, that's when we'll start to do the diagnostics. We'll do things a little bit earlier if there is an underlying or pre-existing pulmonary condition or the patient seems to be getting worse. Our typical evaluation involves a chest CT and a pulmonary function test. As I mentioned earlier, we do see a lot of anxiety and depression coexisting as part of long COVID, and we'll treat that as appropriate. We also hear a lot about sleep issues, either too much or too little. We've also found many patients to have undiagnosed sleep apnea. Now, I'm not sure if that has to do with the fact that it's related to long COVID or the fact that we're just testing more frequently because individuals have troubles with their sleep. But we have found this, and if patients are treated with CPAP, they have a significant improvement. The biggest bucket by far that we deal with when it comes to a targeted evaluation are neurological conditions. The more that I get to work with long COVID, the more I feel that this is truly a neurological phenomenon that we are dealing with. So we see a lot of headaches, and we treat that like any other headache problem. We hear a lot about tremors, both internal and external feeling, and that has responded well to things like propranolol. Taste and smell difficulties. Now, we all remember during the acute COVID infection that this can cause taste and smell problems, but some folks, they will have ongoing problems for several months. The good news is that most patients are going to get better, with studies showing that only about 5% of patients have ongoing problems after 6 months. but that can be a pretty miserable 6 months if you can't taste and smell well. So patients often ask, what can we do to make this go faster? The only thing that we have found to be helpful, both in research and anecdotally, is olfactory retraining. And just some information here. Overall, olfactory retraining involves smelling certain substances routinely in order to help the nerves that are involved in taste and smell regrow, which is possible because they have neuroplasticity. Another thing that I want to mention with the neurological side of things is dysautonomia. Now, to grossly oversimplify, the autonomic nervous system is part of the nervous system that takes care of all the things that we don't normally pay attention to, like sweating or our blood vessels constricting when we go from standing to sitting or vice versa, and so forth. If there's a problem with that part of the nervous system, you can have all sorts of different symptoms, which you see here in this slide. And if those look familiar, that's not a coincidence. There have been several case reports and studies published, including our own, where we have found autonomic dysfunction occurring after previous coronavirus infections and after COVID-19. So with that, our program pays a lot of attention to autonomic testing. We do things called an autonomic reflex test, which includes both a tilt table and a test called a QSART, which measures sweat production from a piece of a patient's skin. And yes, that's a piece of skin that's still attached to the patient. And if needed, if we find a pathology there, we will often use some of the measures that are used to treat things in autonomic dysfunction, especially some of the things that are used to treat a similar condition called postural tachycardia syndrome, otherwise known as POTS. All right, final step, rehabilitation. We all know that any medical condition, if it puts you down and out, even for a day, can result in deconditioning. And this appears to be especially true for the coronavirus. In fact, some studies show that 41% of patients with an acute COVID infection will have decreased ability to exercise afterwards. And that makes it hard to do anything like walk any distance, climb a flight of stairs. Patients also can have difficulties with the mental capacity, such as using a computer. So what do people do when they feel this way? Well, they lace up their sneakers, they hit the gym, they turn on the 80s movie training montage music, and they tried to no gain, no pain their way back to good health, perhaps in a way to beat out the COVID condition. Unfortunately, this is exactly what patients with long haul COVID don't want to do. That's because patients with long haul COVID, we have found, experience post exertional malaise. Now, what is this? So, post exertional malaise is fatigue and flu like symptoms that can last for hours, even days after minimal physical or mental activity. And if that sounds odd, just realize that this is something that we have seen quite frequently in myalgic encephalomyelitis and chronic fatigue syndrome. In fact, almost 30% of patients with those conditions report having post-exertional malaise after activity. So the important takeaway point when it comes to rehabilitation and long haul COVID is that rehabilitation does not equal exercise. Instead, what we promote is something called an adaptive paced therapy. Another way to describe it is low and slow. And I mean really low and slow. It can be quite shocking how much of a setback patients need to experience in order to start their recovery. So for example, we've had patients who are marathon runners who develop long COVID and they go from running 40 or 50 miles a week to just doing leg extensions in a chair against gravity as part of their initial recovery. It's also really important to remember that this adaptive therapy, it's individualized. We use each person's personal experiences to set the baseline levels that we start at and to progress forward. So for example, if someone can walk for 10 minutes without experiencing post-exertional malaise, we may start them there for about a week and then increase perhaps next week to 13 minutes of walking. We also don't push patients. The progression of a person's activity levels are done in conjunction with the idea that we want to avoid any onset of post-exertional malaise, as we feel that those are periods when the inflammation and stress on the body prolongs the long COVID state. And finally, this is also not simply a stop when it hurts philosophy. Remember, many patients are resting in between their periods of activity. So it's very easy for them to overdo things when they do try to do something. For example, I had a patient once tell me that he was feeling good, so he decided to go for a 20-block walk around New York City, and that went well. Well, unfortunately, he didn't walk for like the next week after that because of the post-exertional malaise experience. So that's our treatment paradigm in a nutshell. Now, you may be wondering, what about medications? And yes, we do use medications to help patients with this condition. And they're all off-label, but you can see here in this slide some of the things that we use. And I won't go into detail there, except for one medication that I want to talk about, naltrexone. Now, naltrexone is a medicine that you probably all recognize as something that we use for opioid and alcohol abuse. Now, we don't think that long COVID has anything to do with alcohol or opioid abuse. When we typically use that medication, it's at 50 milligrams, 50. But there's also a low dose version, roughly with between 1 and 4.5 milligrams, that works in a different fashion. At that kind of dosage, what researchers have found is that naltrexone acts as a glial modulator, basically affecting the immune system. And it specifically binds to a toll-like receptor 4, which leads to a decrease in tumor necrosis factor alpha and interferon beta. It also results in an upregulation of the endogenous opioid system. So because of this, we've used this medication at a low dose with some success for things like Crohn's disease, fibromyalgia, and multiple sclerosis, and now with long haul COVID. There was a small study published last year where they looked at 36 patients to see if there was any improvement in long COVID following 1 to 3 milligrams of naltrexone over 3 months. And what they found was widespread improvements in function, sleep, concentration, and pain. Now, this is not a perfect study by any stretch of the imagination. You can see the limitations there. But because of the excellent safety profile with this medicine, we have used it in several of our patients at Mayo Clinic, and it's part of our treatment regimen. And I can say that of all the medications that we have tried for long COVID, this one seems to be making the most improvement. We've had patients who have been plateaued for a year or more, be on this medicine, get started on this medicine, and have significant, if not full, improvements. So with that, that's my last slide there. And 1 minute over, I'm sorry about that. This is my contact information, and I'll be happy to take any questions later on. Thank you, Dr. Kavanaugh.